So what I was asked to speak about today was blood pressure targets and thresholds. Here are my disclosures. There's really nothing that I'm going to speak on today that's in relation to any specific drug, but you will note that I have done industry-related collaboration before. Okay, so the objectives of today's session are to go over treatment thresholds and treatment targets as recommended by the Canadian Hypertension Education Program, and that's the task force that I chair. In terms of thresholds and targets, the ones that I've chosen to present today are the ones that are more controversial. So today we're going to discuss thresholds and targets in the very elderly, in patients with diabetes, and we're also going to discuss then just the general uncomplicated patient. And we're going to talk a little bit about the SPRINT trial as much as I can, given that the trial results are not known. How many of you have heard of SPRINT? So quite a few, okay. So thresholds and targets in the very elderly, and I don't mind, this is not going to be a half an hour, so I don't mind if you ask questions as we go along, or you can save the questions until the end. So just a couple of background slides about the very elderly. The first one is from the Framingham Study. So this study looked at about 4,000 or 5,000 individuals, and this would have been the subgroup of individuals that were aged 65 at the beginning of the baseline, at the baseline assessment. And so they followed these individuals over the span of about 20 years to see how often they developed high blood pressure. And it turns out that your lifetime risk of developing high blood pressure, if you're 65 at baseline, is almost, well, it's over 90%. So the point here is that if you live long enough, you are technically going to develop high blood pressure according to our definitions. The second issue here is what kind of high blood pressure do the very elderly develop? And I'm sure most of you know it's the isolated systolic variety. So this slide shows that as we age, the systolic blood pressure increases and the diastolic blood pressure drops. This is due mostly to arterial stiffness, and so you get isolated systolic variety type of hypertension. So I think many of you are fairly familiar with these thresholds, but I'm tasked with giving you the rationale behind them. So in the very elderly, CHEP recommends a treatment threshold for initiation of drug therapy of 160 or greater. So if the blood pressure is 160 or higher, we say that is a reason to initiate pharmacotherapy in the very elderly. And by the way, very elderly for CHEP is 80 years or greater. And then we say if you are going to then treat these individuals, drive the blood pressure down to at least less than 150. So you can see that the thresholds and targets are pretty conservative in this age group. And we do worry about leaving strokes, residual risk on the table, but the recommendations follow with the data that is out there until better data become available. So most of the recommendation hinges on a trial called the Hiva trial. I'm not going to show you the whole study for any of these studies involved. I'm just going to give you snippets of the main results. The Hiva trial was a trial of about 4,000 individuals. It was published in the New England Journal in 2007. And essentially they randomized these individuals to active treatment versus placebo, and they used those thresholds and targets that I just mentioned. So these were individuals with a blood pressure of 160 or greater, and they aimed to, in the intervention arm, reduce the blood pressure to less than 150. You can see here that the mean age was over 80, so 83 years, and the average blood pressure was 173 systolic. So the Hiva trial results, the blood pressure over time is shown here. So you can see here that the baseline blood pressure for systolic above 170, so they got the blood pressure down to less than 150 pretty quickly. within the first year, on average, most people in the intervention arm, well less than 150, and then came down over time, such that near the end of the trial, they were actually near 140. Now here are the results. So a number of comments here. So the primary endpoint was fatal or non-fatal stroke, and that was reduced, but you can see the p-value was 0.06. So the trial was stopped early, and at the time that they stopped the trial, I believe the p-value was less than 0.05, but you can see how it hinges on a few events. So after a few more events were counted, the p-value was actually not statistically significant according to conventional thresholds. When we also look at death from stroke, so that was significantly reduced. It's a kind of borderline p-value, but it was reduced. And death from any cause, all-cause mortality, was reduced significantly. Now, the all-cause mortality question is important because previous hypotheses were that aggressive treatment in this patient population actually increased mortality. Oh, thank you. And so that's why this question, death from any cause, was one of the important secondary endpoints. And this trial kind of, I would say fairly unequivocally, showed that treatment in this of blood pressure reduction in these individuals in terms of aggressive blood pressure reduction did not increase the risk of death. So because of those limitations, number one, the fact that the trial was stopped early, number two, that the p-value was borderline and they did not observe their pre-specified stopping rule, and number three, the fact that the individuals enrolled in the trial were not so generalizable. I mean, they were generally the sort of the country club, very elderly, the people that were quite healthy compared to some of their compatriots or colleagues in that age group. For those reasons, it's a grade C. But this is now what we recommend and have recommended for several years. Is this going to change? Possibly. So I'm going to show you SPRINT in a minute. This may be too conservative given the results of SPRINT. Diabetes. So here we have our treatment targets and thresholds for type 2 diabetes. We are one of the only guideline organizations that still recommends a threshold of 130/80 and a target of less than 130/80. And we've chosen to be aggressive because we believe this population is a very, very high-risk population. The data I'm going to show you, they're okay, especially for that systolic target, maybe a little bit stronger for diastolic, arguably. And other guideline organizations have been in the business recently of rolling back targets. So some guidelines go with 140/90, some go with 135/80 or 135/85. I think we're one of the only ones that are still at 130/80. So you probably can't read this, but this is the study design for the HOT trial. The HOT trial forms the basis of the diastolic results, diastolic threshold and target. So HOT was a study that enrolled approximately 20,000 individuals, pretty well conducted study. And basically in HOT, they enrolled these individuals and they treated them to less than 90 diastolic versus less than 85 versus less than 80 diastolic. So 3 different diastolic treatment thresholds. Now, the overall result of HOT was a null result. So null finding in the entire group of patients looked at in the study. But in the patients with type 2 diabetes, that was about 1,500 of them. The result was that those driven down to less than 80 had about a 50% risk reduction compared to those less than 90. And so this forms the basis for our diastolic threshold. Now there is some controversy, admittedly. Some people feel that the HOT trial did not pre-specify diabetes as an endpoint, but if you look at the protocol paper, we believe they did. It's one of about 4 or 5 pre-specified endpoints listed. They could have done it in a much stronger way by using better terminology, but we accept that it was pre-specified, and this is the basis behind the diastolic threshold. So the systolic threshold comes from data such as this. So this is a meta-analysis of 13 trials, almost 14,000 individuals. So it was published in Circulation in 2011. This slide looks at all-cause mortality, and you see that in patients with type 2 diabetes enrolled in these studies, if the systolic blood pressure was driven down to less than 135, then the odds ratio here, or the relative risk, sorry, was 0.87 and 0.79 to 0.95. And then you see here less than 130 and a relative risk of 0.9 with a confidence interval of 0.83 to 0.98. So the number needed to treat is fairly high if you work out the absolute risk reduction and do the math. But it is some evidence for reducing blood pressure below 130 systolic. The major limitation to this meta-analysis is that a lot of these trials were not treat-to-target trials. So they didn't randomize people to different thresholds. They are just using the achieved targets in the trials, and so that is a limitation. We would rather have studies that actually randomize to different thresholds. And again, in this meta-analysis, you look at the results of stroke. So the case for driving blood pressure down is probably most compelling for the endpoint of stroke. And we see here a relative risk for 130 or less systolic blood pressure achieved of 0.83, 0.73 to 0.95. Now, one of the major criticisms of doing this is that one will precipitate adverse effects, and yes, that is true. And this was shown in the ACCORD trial, which randomized individuals with type 2 diabetes to a blood pressure of less than 140 versus less than 120. And the achieved blood pressures in that study were 133 versus 119. And ACCORD had an overall null result. It was one of the studies included in that meta-analysis. But there was an increased risk of adverse effects, namely dizziness, syncope, hypotension. And these I don't want to dismiss, but they're not the same as stroke, heart attack, or death. And so we do have to weigh the relative severity of the adverse effects versus the more serious complications in terms of endpoints. Now, I think ACCORD probably, unfortunately, was also null because of the factorial design, and it looks like there was interaction between the blood pressure arm and the glucose lowering arm. It was a very complicated trial. And so because of that, unfortunately, we don't have a good answer in terms, I wish we had a better answer in terms of intensive blood pressure lowering in type 2 diabetes. There is a trial ongoing right now called the SHOT trial, S-H-O-T, maybe not the best name